Saya tutup saja. Dah tutup? Dah tutup kan? Oh ni speaker ni kena tutup. Tak speaker saya kena tutup.
Terus cuba cakap.
Hello? Hello?
Oh, so use this one.
Use that one.
Alright. Anyone listening?
Can you hear me?
Yes.
Clear.
Minum dulu lah. Minum dulu. Nak break makan dulu ni. Sampai makan. Makan. Siapa kita start je. Dah habis cepat kan kalau nasi pula panjang pula. Terima kasih. Kalau nasi aja dah. Dia bagi dia. Oh ya ke? Habis siapa yang lambat? Yusuf. Tak boleh ke belakang. Boleh nampak saya ke? Saya kena kamera ke?
Saya buka, kalau buka kamera power.
Okay. Assalamualaikum dan mana sini. And good morning. Hari ke berapa dah ni? 60. Okay. So congratulations for your insistence, struggle, marathon, but yet you still have a lot of time to study after this. You know it's going to be postponed. Inform the kuliah that because of the PKP, we're going to postpone until what is happening to PKP, because at the moment they won't allow any exam to be taken. So they won't allow exam to be conducted during this PKP time. We can start. The topic given is principle of surgical oncology. I think this is very important topic in terms of your practice to surgery, because I think now cancer is the commonest causes or commonest disease that you're going to face during your practice everywhere now. Be it solid cancer, hematological, you still have to deal with this type of cancer. So the principle of oncology is there any surgical oncology? Is there any term surgical oncology? Yes. Surgical oncologist. I remember when I was practicing in HTA last time, toward the beginning of my practice in HTA, there was a surgeon employed by KKM named surgical oncologist. He was from India. So he dealt mainly with the cancer. So he can do breast surgery, he can do thyroid, he can do what is this? He can do the colorectal. But the problem is dealing with benign. They are not very familiar. So now you have to think of the surgery is more of the everything basically. It's holistic, you know. So and the knowledge of surgery, the knowledge of the field itself is so broad that actually now you need sub-specialization in general surgery itself. That's why I think we more concentrate on the anatomical subspecialty, like hepatobiliary, colorectal, breast, endocrine, because if you're being a general surgeon, I don't think you can go with the knowledge and the technology they're coming in with it now. So this lecture basically evolved around the history of surgery and cancer, understanding of cancer pathology, which is very important for you. I think you have this topic covered, isn't it? Cancer pathology, neoplasm, all that in this series of lectures. I think when I have a look, I think I don't have to cover that much. A role of surgery, role of surgeon involved in the management of cancer, integration of other modalities, for example, radiotherapy, chemotherapy, what else? Biological drugs, for example, antibody, okay, and principle of oncology surgery itself. So I think this is the topic that I try to cover and discuss with you for this lecture. Are you familiar with this? Most likely, like the CPC recently, a huge germ cell tumor ovary. Most of the time, the huge one. But having said that, I think we operated one in our case kan ada jumpa itu a big mesenchymal tumor. Ada, tidur hari ni. Okay, this is the scenario that you will see in the practice, huge tumor, and this is the surgery that we're going to do, involve, for example, laparoscopic evaluation. This is sentinel node, excision or wedge retraction of the liver for malignancy, and this is excisional biopsy. Reconstruction is part of it now as well. If you see, this is a breast surgery and reconstruction of the breast itself at one stage surgery. Okay, the history, if you notice, it goes back even before 400 years before century in Egypt, where actually it was documented. It was documented actually one of the first surgery done by the female surgeon in Egypt for mastectomy. They did mastectomy at that time for the growth in the breast. Okay, that was in Egypt. Of course, circumcision was done there as well in Egypt before. This is a few pictures that I got from the internet, but it's actually a long history. First, if you're interested in the history of surgery, there's a book specially written on history of surgery. So you can see the evolution from time where surgery evolved. This is again taken from the book History of Surgery, tumor removed by surgery in 1689. This is all tumor, so the tumor has been there for some time. If you see this is what parotid, isn't it? Like the one in the exam recently, for part 2, and they still insist that it's thyroid. So this is a huge parotid tumor. They did surgery, but they didn't show the facial nerve palsy on this patient. So it's probably a successful without affecting the facial nerve. It's one of the known complications. If you remember the anatomy, especially ENT, you have to well versed on the anatomy of the parotid. It's like a burger, the facial nerve between the deep lobe and superficial lobe. So the nerve is just sitting in between. It's like a burger. Again, surgical operation to remove a malignant tumor in 1817. This is more Western. I think it's more like breast cancer. But with the advance of intensive care, with the advance of antibiotic, and with the advance of general anesthesia, we can actually refine the surgery. And okay, this one is radical mastectomy, which was done by Halstead from Johns Hopkins in US, where he did radical mastectomy from 50 cases between 89 to 94. So the operation was good, but the survival is still the same, even though they removed the cancer. You know, probably now we know. At that time, they think by removing the cancer, that's it, there is a treatment. But now we know it's beyond that, it's more than that needed for the management of patient with cancer. So what I'm trying to say is surgical oncology, surgical in managing a cancer is more than that. The knowledge that you have to gather is more than surgery. Of course, you have to update yourself, you have to learn the recent technique, the update on the surgery, but yet there is a lot of other things that you have to learn. That's why I think we end up with doing subspecialty, because it's too much for for the whole lot. Okay. Again, I think en bloc resection is one of the concepts where you actually remove the whole of the tumor without sacrificing the age. And the first, I think you're all familiar with the Whipple operation. Kan? Whipple operation, 1935 by Dr. Alan Olfado Whipple, the surgeon-in-chief in Columbia Presbyterian Hospital, again in US, I think. So is there surgical oncology? Yes. 50% of the patients who are presented, who are presently cured from cancer are cured by surgical resection alone. Yes, about 50%. I think now you're talking about less. But if you detect it early in a cancer case, you probably cured the patient by surgery alone. Surgical oncologists, a distinct discipline within surgery? It was yes. But now I think it was actually, I show you on the next slide. General surgical oncology versus anatomical site specific. I think now in Malaysia or even all over the world, it's more on the anatomical site specific surgeon. Okay, so you concentrate on the colorectal, you deal with the oncology and benign disease of that region. Okay, that is more toward that now, I think. Okay, I think in 2011, American Board of Surgery tried to have this a surgical oncologist, a well-qualified surgeon who have obtained additional training and experience in multidisciplinary approach to the prevention, not only treatment, to the diagnosis, treatment, and rehabilitation of cancer patients, and devote major portion of his or her professional practice to this activity and cancer research. So that was 2011, and after that, that is not going, I think. I think it's more still regional and anatomical side surgeon produced after that era. So why we need cancer surgeon? Why we have to be good in that area? Because you have to understand the biology of the disease. Okay, that's what we are doing now, learning all the basic knowledge of the disease, update on modality of treatment, learn, update, and perform cost-effective surgery, develop clinical trials, guide advanced disease management, and evaluate the outcome of the management. So this is what is needed to be a cancer surgeon. Okay, I just show the epidemiology of the cancer in Malaysia from the latest. Unfortunately, it's not in there in KKM. I was trying to search, but this is what we get 2007 till 2011. The epidemiology that was presented in the cancer registry of KKM. Okay, in Malaysia. So the breast by far is the leading, and then the colorectal, and then the lung, lymphoma, nasopharynx, leukemia, cervix, liver, ovary, stomach. So you notice breast and colorectal is the most number in Malaysia. That's why I think if you are interested in these two, you are talking about the volume where you can develop. Okay, liver sikit je Haris. Stomach lagi sikit Haris. So untuk operatif kalau nak kerja relax, pergilah liver. Sikit-sikit. Because most of the time, by the time they come to us, even with that 4.2, about 80% is not resectable. By the time they come, about 10% only is operable. So there is. So kalau nak relax, pergilah liver, stomach, apa je. I'm sorry, we're talking about ni general surgery. Boleh the incident because nasopharynx banyak 4.9. Nasopharynx is the NT 4.9%. This is Malaysia. Okay, and by gender, by sex. Again, colorectal for male is number 1. Prostate here is number berapa ni? 4, 5. Liver number 6 lah. Stomach, bladder is lower. Again, female colorectal, cervix. Okay, this is the figure. But anyway, this is 2011. But I think the distribution are still the same according to the system. I think over here you probably notice colorectal busy again compared dengan liver in terms of cancer, in terms of cancer surgery. Kalau sibuk tim B lagi rasanya kan. Tim B lagi sibuk in terms of works. Maybe because of the breast as well, because we're dealing with breast, and there's a lot of surgery in breast. If you notice, Syahida always sibuk with breast surgery. So colorectal and breast is still number one kan tadi? Breast is the number. So the volume wise is very high, the breast and colorectal. Huh? No. After we were sending one, as masa balik boleh separate. So kurang sikit lah apa tu beliarin apa GI. Okay, this is the epidemiology. So what I'm trying to say here, the number is increasing, and there is the need of subspecialization on that. Okay, because of volume. If you do general surgery in a hospital like this, single, you do everything. Bila, to update your knowledge, to cope with the numbers. That's why I think we go for specialization, subspecialization. We go back. I think you have revision on this. You have this. What is neoplasm, malignant, benign, and carcinoma in situ. I think one of the important here I wanted to show you is carcinoma in situ. Has pathological characteristic of malignant tumor, but with no detectable invasion into the surrounding tissue or infiltration into deeper cell layer. Nak senang cerita, make it easier for you, no invasion to basal cell membrane. Okay, that is carcinoma in situ. Cancer pathology, classical neoplasm, you would have cancer. You have this is for solid cell, solid tumor. You have carcinoma and sarcoma mainly that we are dealing with. Okay. There's again the cancer biology that you have to know is the grading of malignancy. You are familiar with this. Histological classification carcinoma into grades according to degree of differentiation, appearance of cell, their nuclear, and number of matrix figure. The first try to study this is in 1914, Albert Broders from Mayo Clinic. He was collecting data for squamous cell carcinoma. What he was trying to see is the prognosis, the survival rate is different, even though they are similar cell type. So when he studied further, he grade the carcinoma, the classify into 4 grade at that time. Okay. Other system include Bloom-Richardson grading system for breast that we are familiar with, and Furman system for kidney cancer. Okay, this is what is commonly used by American Joint Commission on Cancer on the grading. GX means grade cannot be assessed. We are familiar with well differentiated or low grade, cells, which is well differentiated. This is the good one basically. And then fully undifferentiated or undifferentiated high grade, which is very aggressive cells. That's how we look at it. I think this is just revision for you, and this is very important concept when we are managing the cancer patient, because with this, the strategy of management will differ according to the grade. Again, the next thing is the route of spread, and in which we will go into the staging of the cancer. I think you are familiar with this direct extension of the cancer to the surrounding tissue, lymphatic spread, vascular spread, capillary are almost invaded, vein invaded frequently, but not, but arteries rarely invaded, mostly vein. and then spread to serous cavity, peritoneal seeding, and Sister Joseph Mary transyloming. This is example of Sister Mary Joseph nodule. I think if you see this, it's not common to have, but I think in our clinical, in our setup, we have seen two, I think. Betul lah, ada Hafiz? Ada. You see this, you don't see this a lot, but you see this is classical, like Sister Mary Joseph basically is what is this, spread of the tumor into the periumbilical area. So you see this, you diagnose this, lulus lah. You see this, you still cannot work it out, masalah. Okay. Okay. Okay, cancer staging is another thing that everybody have to know, because what is the meaning of staging? This is to determine the extent of the tumor invasion, either local or distant. We can broadly classify into early, locally advanced, and metastatic disease. It is assist in determining optimal managing strategies. Directly correlate with prognosis. Example are TNM staging and Duke staging in colorectal carcinoma. So anyway, when you deal with the patient with the cancer, the first thing you have to assess is the stage, because your treatment strategy will be based on the stage. Grade itu kemudian lah, stage. So is it early cancer? Is it locally advanced? Is it resectable? Or is it a metastatic disease? Based on that, you actually design your treatment strategy for that patient. So again, by having that, you know what kind of prognosis the patient has. Okay. But obviously, this is a very simple way, because obviously when you're talking about others, again, this is staging is usually you're talking about the solid tumor lah. Hematological will be different staging altogether, and again, it's not as simple as TNM. For example, liver. Liver, you're not talking about just TNM. You combine that with the ECOG status of the patient, functional reserve of the liver, of that. So, but the main thing is, any cancer, you have to stage the cancer to know the advance the advancement of the advance of the disease, or the prognosis, of that disease. Okay, so staging is very important. How do you do staging? There's a lot of ways. Start with the CT scan. You probably need a PET scan. You probably need a bone scan, and laparoscopic, for example, EUS. Is all a lot of way to do a staging of a disease. This is an example of colorectal staging, TNM. I think we still use TNM kan? Duk sudah tak pakai dah kan? Sudah tak pakai kan? Okay. We'll correlate with the stage, TNM, and 5-year survival. Tumor marker. Saya tak payah cakap banyak pasal tumor marker, because I think you have one lecture special on the tumor marker. Betul lah? You are talking about tumor marker related to what cancer, the sensitivity of the tumor marker to the specific cancer, and the specificity of the tumor marker for the specific cancer. But mainly, I think it's for the follow-up, isn't it? Give, for example, in hepatocellular carcinoma, that will help you in the management. So the sensitivity is about 98, specificity is 65. Again, even the tumor marker is not elevated, give you example in liver, still you suspect the malignancy. So in terms of specificity, is quite low for liver. That's why it's 65%. Ada makanan lagi? Lunch. Lunch apa lagi? Okay, what is the role of surgeon in oncology management? Surgery makes a contribution to cancer treatment in concert with other modalities. Advance in the treatment of cancer will derive from improved orchestration with other modalities rather than from improved operating technique alone. This is spoken by Bernard Fisher in 1917. In other words, we are only small part of a big team that managing the cancer. So we are talking about multidisciplinary. That is the first principle. Managing a cancer must involve a multimodality. You don't decide alone. I think it's now with the advance of even Zoom and Google Meet, we can discuss this in a lot of ways. Okay, so I think managing cancer alone is a big since now. Okay, so there is a patient with cancer. Surgeon, ideally, surgeon will be the main focus, the main player in the management because patient come to surgeon kan. Bukannya patient come to the nurse, rehabilitation, pathologist. Patient come to us, and we will organize the discussion, and we are the main focus for the management of that case. So we need a pathologist definitely to discuss. We need a radiologist. Okay, like I think we are all familiar with this. Because when I first came to Kuantan, we don't have this. We don't have multidisciplinary. That was how long I have been here? 20 years, Haris. 20 years. Okay. I've been here for 20 years. 2001 and 2001. We don't have multidisciplinary approach managing the case. We just decide, call the oncologist. I've done this. Can you give him more? That's all. But now I think we decided earlier before even starting the treatment. We were starting the surgery. We discussed with everybody. We have the input from oncologists. We have the input from radiologists, pathologists, physio and rehabilitation, and nutritional nurse. All that we have to. Nutrition is very important. For example, if you are managing a patient with the PGI, this all come together and we discuss. So again, it's multidisciplinary approach nowadays. I don't know, Saza, if you are dah tak ada kan sebab you UMS lah. I don't know if you are thrown to Tawau, for example. Ada ke semua? Tak ada. So what are you going to do? Call email. And now with the Zoom and the Google Meet, I think you can contact like what we're doing now. I think with that kan. No, I think that is the new approach. It's evolved. Yes. 2001 when I first came, no. None. But now everybody, I think because of the litigation, all that come, so it is better for the patient outcome and better for the management outcome. So it is good that we have this. Adalah orang backup kita yang bolehlah discuss panjang sikit. So again, I think this is a must now, multidisciplinary approach, multidisciplinary team approach to managing a cancer patient. So what are the roles of surgeon? You are involved in the diagnostic, in the staging, prognosticate, curative, restorative, palliative, and prophylactic. Okay, this is the diagnostic. We are familiar with biopsy, true cut biopsy, FNAC, core biopsy, surgery, excision, incision. You're all familiar with this, but I think for you, you just send the patient for this. I used to do all this alone, FNAC do alone. Masa saya jadi trainee pun, masa itu saya buat fellowship. When I see the patient in the clinic, breast clinic, I do the FNAC alone. We have all that experience. Of course, sempat kan? We do it alone. Which is, I think it's not satisfying. It's better because we know the patient and clinically we know them better. So that is better and it's more targeted toward what we need. Okay, this is better. So even you have to know how to put the cell smears on that on the slide. You all know about that, I used to do it. But now everything is just order through the form and give it to them. And the ideal situation is you have to get the ultrasound first or the imaging first before you do this, because distortion of the structure because it can cause bleeding, for example. So it actually will distort the anatomy of the tumor itself. So the ideal situation will be do the imaging and then do biopsy. But you know lah, imaging take about 3 weeks or 2 weeks, minimum 1 week. And then you send for the NSC, they give appointment another week. So the report 1 month after that. So you are talking about 6 weeks altogether. The ideal situation that is not good for the patient. And the situation we have to get it done. So that's why we did at that time we did it ourselves. But now I think it's a quicker lah kan. Kalau you order pun dalam seminggu boleh kan. Tak boleh juga. 2-3 minggu. Through biopsy, we have the needle in our own clinic. We can do it ourselves. We do it ourselves kan through biopsy. But one of the problem is you send the histology, you send the TrueCut, they won't commit the diagnosis and make it difficult for us. And that is the commonest thing. But again, for them to commit is very difficult. You probably heard in UK, there was series of mastectomy done because reported FNSC as malignant. That was years back. And when the review again turned out to be non-malignant cells after mastectomy, a lot. So that's why I think the histology is a little bit reserved to comment, which is fair enough. I think if you're not sure, jangan cuba-cuba pandai lah. The clinical, yes, that is the usually. I think we repeat again until we're happy. Because to us, to decide is very difficult. For them, it's difficult as well. So both ways is difficult. It's not easy dealing with this because the consequence and the management. Okay. And then biopsy can be FNAC, core needle, surgery, excision, incision, and then or probably doing surgery, open and laparoscopic, and we are involved in the diagnostic, and you have to be familiar. So actually, you have to know how to do laparoscopy surgery to take a biopsy from the mesentery or from the liver nodule, for example. You have to do that. So you have to know that knowledge to be a surgeon. Okay. We are involved with the diagnostic. Okay, this is typical macam breast ya kan? Excision biopsy breast ni ya? Skin lesion. Okay. Okay. Again, for staging in surgery, for example, we involve in the staging of the disease, laparoscopy, locally advanced GI malignancy, axillary surgery for breast carcinoma, EOS, for example, we have to do sentinel lymph node biopsy, axillary surgery for the breast, kan? Stage 1, level 1, level 2, level 3, but this is more on the terminology lah. This is example of the staging that surgeon do, and this is the laparoscopic with ultrasound probe, laparoscopic probe for ultrasound. We do have this, and we're doing this, and this is typical sentinel lymph node biopsy, where in this case you injected with the dye, and ideally we have to use both radioactive substance and dye into the surrounding area of the tumor, and then the first nodes that is taken up, the dye and radioactive, is considered as sentinel node. Dia kalau tengok cerita metrik tu kan, pernah tengok cerita metrik kan, dia punya point tu lah, that is the cerita metrik. Keanu Reeves lah kan. That is the sentinel node. Okay. And then, of course, our intent will be doing a curative surgery, which is a total excision of all tumor cell. In reality, almost impossible. but we try to do this. We have to have adequate margin, adequate section margin. R0 is microscopically negative, R1 microscopically involved, R2 is closely involved. And lymph node dissection as well in some tumor, for example, is gastric tumor, you have to get the lymph node dissection as well, is the certain station of the lymph nodes. And the next is restoring option as much as possible, restoring the function of the organ or tissue itself. Okay. The concept of en bloc resection is very important for the clear margin. Okay. This is apa ni? For definitely this is liver. Stomach kan ni? This is liver. This is gallbladder. This is colon. Okay, so you take everything out, and this is small bowel. So what I'm trying to say is en bloc resection is the concept where you take the whole lot and clear the margin. Hopefully, the tumor is not involved in that cutting part of the area of your resection, and that is the concept of en bloc resection. Also, there is cytoreductive surgery. We don't do this. I think general surgery tak ada kan cytoreductive. As far as I know, we don't. But it's a lot done by the ONG, especially in ovarian cancer. I think if you attend, you attend CBC on Friday. There are 2 cases of 14-year-old and 18-year-old huge ovarian cancer, and they did the cytoreductive surgery. Cytoreductive is a partial surgical reduction of the tumor to improve the ability of other treatment modalities to control unresectable residual growth disease. Benefit only when other effective treatment are available to control unresectable disease. So, in other words, it is beneficial when you have the chemotherapy, for example, or radiotherapy. Otherwise, you don't do the chemo. There's no point to do the cytoreductive surgery. Okay, but it's working very well in the germ cell tumor for ovary. It worked very well. Okay. Okay, this one is, I mentioned before, restorative surgery to return the organ or system to its original anatomical and functional state as much as possible. Example is breast reconstruction surgery, reconstruction post maxillofacial tumor resection. I think esophagus layering, they call it layering, where they do a long surgery usually. And then typical is our Whipple procedure. You all familiar with this, where you actually remove we do the hepatico-jejunostomy, pancreatico-jejunostomy, and this is pylorus preserving the stomach or the pylorus to the jejunum. This is pylorus preserving surgery. Okay, so we remove this part and block, and then we do the reconstruction for the normal function of the system. Of course, with this so many anesthetics, there's very higher risk of complication. Okay, surgery also we do a palliative. Patient should be better at the completion of procedure. Patient should be relieved the symptom, or patient beyond cure when non-surgical measures are not feasible, not effective as not expedient. To control the pain, relieve gastrointestinal biliary obstruction, stop hemorrhage, supplement poor nutrition. Example here is patient with gastric bleeding. You know, the only way to stop sometimes, there's now a lot we can do radiological intervention, all that. But in the old day, if you don't have, you do the resection for palliative resection to stop the bleeding. That is the only way to do. Again, in the liver cancer as well, if it is bleeding, you probably end up with the resection just to stop the bleeding. It's not curative, but it's palliative to stop the bleeding. Okay. So the patient should be better at the completion of the procedure. Not worse, so it was you don't do surgery. I give an example, palliative that you put. I don't know. There's a lot of argument on that. If somebody cannot swallow, either you put a RELS tube or you do a gastrojejunostomy. Which one do you prefer? For palliative that you know is not going to last for a few months, for example. But there's still a lot of argument whether you are going to proceed with gastrojejunostomy. But it's still, patients should be better at the completion of the procedure. One the better, do you think? Patient, we are talking about palliative, you know, palliative. So, but still, I think there's pros and cons. Debatable. You can debate. You can win either way. Okay, boleh saja. Okay, palliation and other obstruction with stent, all that. This is typical what you do for gastroesophageal junction tumor. Okay, another thing is prophylactic surgery that where you do. Siapa ni yang breast cancer tu siapa nama dia? Angelina Jolie kan? Prophylactic mastectomy, for example, to prevent the development of cancer, if it is very obvious lah. Familial adenomatous polyposis (FAP), 50% develop colon cancer by the age 40. I think this is indicated lah, definitely kan. By age 70, virtually all develop colon cancer. So prophylactic proctocolectomy before age of 22 CRC is recommended if the patient carry APC gene. Okay, is recommended. Okay, tapi breast cancer we can argue, boleh tak? Kalau BRCA tu. What is your opinion on that? Ini kita kepada Islamic input ethical issue Islamic. Boleh, bukan imam but you have to have an idea kan, because you will soon with the advance of internet, you know, patient will come and see you. I want to have BRCA done. I'm positive. Come to see you, but I want to have mastectomy. What is your opinion on that, Haris? Ada masa kan? Ada banyak masa lagi nih, insyaAllah. Tak banyak nih, ada sikit lagi.
Changing something yang
tapi nak dapat cancer ni. Tak berani. Afiq, what do you think, Afiq?
Apart from maternity approach, you have to based on patient preference juga. But I think there's no black and white on the
Hukum.
Because it's more.
Saya kena panggil fatwa lah, bagi fatwa lah.
Kasih syariah, save life first.
Nah, makasih saya first save life. Tapi kalau ada cancer,
boleh lah.
Kasih syariah patient tak ada cancer. Procedure normal.
So tak boleh nak kata.
What do you think? This is Islamic, but what do you think yourself? Your article. What do you think? No, we have makasih syariah. Syariah say life first. So you have to save life first.
But I think it's not necessarily a patient's choice.
Patient's choice.
You must have got evidence of clinical base to double escape well. If she can accept and she wanted it, you couldn't say no.
So patient is the
Patient is the main factor.
okay. I'll give you another example. When you say patient have the right, okay, I'll give you an example. A patient diagnosed by GP, gallstone, asymptomatic. Doctor, I want to have this done, surgery done for me because I'm worried of complication, I'm worried of cancer. Because when she read the internet, gallstone, there's a chance for you to develop cancer. Betul, same thing. So what is your opinion? Are you going to offer another question?
But this one she still have to, okay, this one is actually depends on your in the government setting or you are in a private.
Yeah. See, you have no, you have no ethic. You have no ethic. You have to have your own.
But for me, I wouldn't advise her for all. Even though it's a patient choice, like you say, it's contradicting.
Well, based on what? That you should have based on what is the principle guiding you.
She first of all she has to understand the disease progressed to be a CA and the risk that she get during the surgery and after the
We're
surgery.
talking about risk. Yes.
So she has to know
Risk surgery dengan risk cancer, which one is higher? At what age he will develop cancer? The studies show you die first before you develop gallbladder cancer. You die first. In other words, 80, 90, you develop cancer. You probably by then die already. So the risk is very low. Your surgery risk is outweighed the risk of developing cancer. In that case, I won't do surgery. I tell the patient, your risk of dying is higher for you when you're having surgery than you develop cancer. And that is what guiding you. Tapi yang the scenario I give you pregnancy is different. Saza, what do you think? What is your name?
I agree with the decision.
Which one? Patient guiding.
No, as in, I agree with Angelina Jolie. She wanted to have the mastectomy because of the genetic risk. So I agree with the decision because there's huge evidence here on how I cannot wait now at my head that she's got a high risk.
She got married, definitely.
Yeah.
But there is ways how to monitor, isn't it? And there is now treatment that actually can cure if you detect it early. One. So you put that all together, you have to wait. Prophylactic, screening, and treatment early. So you have to wait. Based on that, decide. That is how we go about lah. Plus, I think for me, for us, there is Makasid Syariah, the Islamic tell us, you cannot mutilate for no reason. You cannot change or disfigure somebody for no reason. That is what we have to put there.
Oh, let's say a person with a controversy.
Controversy is
No,
different.
controversy on one side, but she wish to remove the other side as a prophylactic.
Oh, yeah, because that is the risk is very high. It's totally different from that one. The risk is very high. How many percentage?
So we do.
We can. But we don't know most of the time because in Malaysia there's no such people like that. We are fortunate probably that way. Okay, boleh sikit lah okay, there is so-called prophylactic surgery. Okay, I want to talk about radiotherapy because this is, I think, it's not covered again in your this, but I think you have to know and you have to read. Is in the syllabus. Radiotherapy, chemotherapy, molecular biology therapy, all that you have to know. But this one is very superficial, I want to cover to you, because this is adjunct to the management of cancer. And I think by hook or crook, you have to know the principle. So I just give the superficial introduction of what is radiotherapy. The biology of it is interaction of ionizing radiation with tissue leads to the formation of highly reactive free radical that will cause DNA damage. Okay, so when you introduce radiotherapy, actually it produces free radical in the cells, and this free radical will damage the DNA. Okay, that DNA damage will actually induce cell death, or kill the cell in other words. Make it simple, kill the cell. But you know, from your understanding of the biology, chemical biology or the biology, when the DNA is damaged, there is mechanism in your body try to repair. Yes, isn't it? They adapt. Depending on the dose of the radiotherapy given or the frequency, you can actually repair. But I think the main basics of the radiotherapy is double DNA, stranded DNA breaks are the critical lesion for radiation-induced cell kill. I mean, the damage or the breaks of the double-stranded DNA structure, that is where actually it kills the cells. So that is the biological basis of radiotherapy. Okay. The aim of radiotherapy is to deliver a precise dose of radiation to a defined tumor volume with minimal damage to the surrounding normal tissue. So, but the problem is how much you can give. The limitation is how much the cell can receive in when you give the dose. So ideally, it's high dose to kill the cell. As I told you, the capability of our body to repair. The ideal situation, you can give high dose, but the problem is we cannot take it too much. So that's why they give it in fraction and multiple doses. Okay, so you have to define prior to the therapeutic measure whether you want to do curative, you want to do adjuvant, and you want to do palliative. These are all the way that you can give it. Curative, for example, there are cancer that is cured. Basal cell carcinoma, I think on the skin now actually is cured by the radiotherapy alone. You don't need surgery by radiotherapy alone. Okay. Adjuvant therapy is a lot in our practice. This is the example of the adjuvant radiotherapy that we give, the breast, increase local control and demonstrate an increase in overall survival. Okay. Rectal cancer, for example, pre and post-operative radiotherapy decrease local recurrence and also show strong evidence of pre-operative radiotherapy increase survival and few other things. So we use a lot of radiotherapy in our management on cancer now. Okay. How about chemotherapy? What do we know about chemotherapy? I don't think you have lecture on chemotherapy, kan? But you have to know. Radiotherapy, you have to know chemotherapy. I give you just the synopsis and summary. Basically, when you are talking about chemotherapy agents, there are two types that we know: cell-specific type and cell cycle specific and cell cycle non-specific. When cell cycle specific means that it affected the cell during that cycle, you know, the G0, M1, M phase, S phase. So it will affect in that cycle. But the cell cycle non-specific affected, it does not care about the cycle. So affecting all the cycle. So work at the specific, this cell cycle, work at the specific cell cycle. Example, S phase is the effect. The S phase is 5-fluorouracil, gemcitabine, methotrexate. G phase, vincristine, and taxane. Cell cycle non-specific, for example, is doxorubicin, epirubicin, and tetracycline group. And you probably have to know that this cell cycle non-specific have a cardiotoxicity. That's why when you give this group of chemotherapy, you have to monitor the heart because they have cardiotoxicity. This we use in breast cancer, for example. We use a lot in breast cancer. Gemcitabine, pancreas, for example. Fluorouracil is everywhere, you use everywhere. Okay, these are common use cytotoxic chemotherapy drug. Bleomycin dalam leukemia, BML, leukemia lah kan. Cisplatin, taxane group in breast cancer, doxorubicin also in breast cancer, gemcitabine, pancreatic cancer, 5-fluorouracil everywhere you use. Okay, these are the commonly used cytotoxic chemotherapy drug. Well, when you're talking about biological therapy, which is I think it's the more advanced therapy, we divided into monoclonal antibody therapy and small molecular targeted agent. Okay. The first antibody approved for clinical use was rituximab against antibody against CD20 for non-Hodgkin lymphoma. That was the first drug which is used for monoclonal antibody therapy. In solid tumor, the first one was trastuzumab, which is used for breast cancer against HER2. Used in the HER2 positive. It's only approved in 1998. That one in 1998 is only approved for metastatic breast cancer, but now even in all cancer. Okay, but it's very expensive. I don't think it's available in blue books. We can order the patient and the patient can pay it. It's available, but it's expensive. This is antibody therapy, monoclonal antibody therapy. Small molecular target agents. This is molecular target agent, drug that has been designed against specific protein in the tumor cell. Example is imatinib. This is the first that they study. Is a small molecular tyrosine kinase inhibitor. It targets the BCR-ABL transforming oncogene in chronic myelogenous leukemia. Also target c-KIT and platelet-derived growth factor. Eventually, they use this a lot for other cancer as well. So these are the commonly used biological drug or molecular drug, small molecular drug for cancer. Trastuzumab. We're familiar with that. Imatinib now we use for GIST as well. This sorafenib, liver, and used for liver. Initially, sorafenib, imatinib used for kidney, but now sorafenib we use for liver as well. So these are the commonly used and the mechanism of action commonly used biological small molecular agent. So I think this is the last slide that I have. The conclusion: there are major improvement in long-term survival of patients with solid tumor. Many of these achievements rest on advance in disease screening, radiation, and medical oncology. Of course, surgery continue to underpin these treatment strategies both in diagnosis and therapy, and will continue to do so for the foreseeable future. So we still have we will be still the main player in managing the cancer disease. But you have to remember there are a lot of other things that will help us in the management of the cancer. Okay, thank you. Any question? Online dengar? Tidur dah.
Dengar, Prof, dengar.
Dengar.
Ingat dah tidur dah. Any question from online, from the room? I think this is very straightforward. Yeah. Okay, thank you. Selamat sempat lunch ni.